Hello, everyone. This is the New York City Department of Health and Mental Hygiene's update on COVID-19 for New York City healthcare providers. Thank you for joining today's call. Please note that you have been placed in listen-only mode. If you have questions during the presentation, please submit them via the Q&A portion of the WebEx, and we will address them as time allows. Joining us to present today are Dr. Madhuri Ray, Critical Care Planning Lead for Healthcare System Support for the agency's outbreak response, Dr. Corinne Thompson, co-lead of the Epidata Unit for our COVID-19 response, and Dr. Jane Zucker, Assistant Commissioner of the Bureau of Immunization, who will be speaking to us more about vaccine planning. And with that, I will pass it off to Dr. Ray.
Thank you so much, Allie. And can you advance the slide, please? So our outline for today is I'm going to give you a very brief update on where we are now, which will lead into the triumphant return of Dr. Thompson to give us an update on epidemiology. I'll give you a little bit on some updated provider guidance that we've recently released, and then our very, very special guest star, Dr. Jane Zucker, is going to tell us about a very hot topic on in your questions, COVID-19 vaccination. As always, a recording of the webinar as well as the slides will be available shortly after the presentation. Additionally, we will have some time for questions. Please put them in the Q&A box, and we will try to compile some of your questions and ask them to our presenters. Additionally, there'll be a short poll at the end of the presentation, which helps us develop content and improve these webinars for your benefit. Can you advance the slide, please? So we're at a very sobering mark where we now have over 1 million deaths due to COVID-19 worldwide. The highest recent burden of disease is in the Americas and Southeast Asia, and of course we're seeing resurgences in several European countries, as you'll see in the maps that I will show you in a moment. The United States is not an exception to this. Cases are on the rise in New York City. And as we have hinted at previously, but as you'll hear more about with our epidemiology, we are also experiencing resurgences in several areas of New York City. At the same time, New York City public schools have resumed in-person classes, and indoor dining began at 25% capacity this week. So given this context of resurgences within New York City, the City Health Department has issued a commissioner's order to reduce risk at non-public schools, so private, independent, charter schools, in zip codes that are determined by our epidemiological data to have increased transmission. And you'll hear just a little bit more about this, but we are working with partners in affected communities to reinforce all guidance and precautions. And can you advance the slide, please? So this is the map that we usually show you. Unfortunately, some of the areas that were lighter are getting darker and darker as we progress in these webinars, and you can see that we've got over 34 million cases, over 1 million deaths, and this map is showing you where the largest increases in cases are over the past week. So this is not the cumulative total number of cases, this is just in the last week. And can you advance the slide, please? So again, this is a picture of just the U.S. And you can see here that we have both the cases and the number of deaths. The number of deaths, as we've mentioned before, the number of cases increases and the deaths increase later than that. So there's a little bit of a lag, as you would expect, between an identified case and a death. But you can see that in the United States, when we were experiencing our highest levels of COVID in New York City in March and April, that 7-day average, rose steeply. It went down a little, it got very high again, down again, and now it is creeping back up. I do want to remind everyone, as we've mentioned before, again, that in March and April, the number of tests was very limited, and so the number of cases that we're recording probably is not reflective of the actual number of cases in the United States. The other thing that I want to mention is that we have exceeded 200,000 deaths, and of course our cumulative is greater than 7.2 million cases in the United States. And can you advance the slide, please? So here you can see, similar to the world map that we looked at before, this is a map of the United States where we are really highlighting cases, areas that have had high case counts in the last week. You can see that New York City is not yet there in the deepest red category, but there are areas scattered around the South and Midwest, and then you're starting to see some areas in the West with high case rates. And can you advance the slide, please? And now we have a real treat. We have the return of Dr. Thompson to tell us a little bit about recent epidemiology.
Great. Hi, everybody. Can you hear me? Hopefully. Can you hear me?
Yes, we can hear you.
Okay, great. All right, wonderful. So hello, everybody. Again, my name is Corinne Thompson. I'm one of the Epi Data co-leads here within the response, and I am part of the webpage team. So I thought today I would actually just take you through what's happening recently. So this, for those of you who aren't aware or aren't familiar, this is our data page. And we update this every day. And just also to say that in addition to all the data that you can see here, we also have it available for download here on GitHub with this link, and that is shown here. Sorry about this. So you can see all of the data that's updated every day. It was actually just updated 10 minutes ago. We update it about 1 p.m. every day. And we have the data here, and then we also have extensive documentation answering a lot of the common questions that we typically get from the press and from the public. So if you have any questions about the data, I'd encourage you to look here first. So we have a lot of information. I'll let you look through the main page by yourself. But just to go through some of the more topical information, the recent data, this was just updated yesterday. So information on this page is from the last 4 weeks through September 26th. So we try to do weekly information ending last Saturday. As you can see, we are starting to see an increase. So we have about a 14% increase from the previous week through the second most previous week. Let me get my calendar here. So from sorry about this, from the 19th, the week of the 19th to the week of the 26th, we've seen a 14% increase in cases. We've also seen the count of deaths has been very low over time, most recently, but we are seeing still a negative increase, or we're not seeing an increase in deaths, which is great news. Just to point you to something of interest, the maps here. This is our case rate map for the last 4 weeks. So the darker the color, the higher the case rate. You'll see very quickly that South Brooklyn is where we are seeing the most cases in addition to, or the highest case rate in addition to Far Rockaway. You can also see the case counts, the actual raw values, if you're interested. And then we also have a table here where you can not only see information by each zip code, but you can sort. So if we're interested in looking at see the most cases, so you can see it was sorted here by the total number of cases. So zip code 11223, which is Gravesend Homecrest, you can see there have been 431 total cases over the last 4 weeks, and you can see here the case rate has actually really dramatically risen. It's a 2-week change, so the first 2 weeks to the second 2 weeks, it's a 115% increase. We do think that this is real. For a while, we were seeing some of these large increases, but very small case numbers. But as you can see here, the case numbers are considerable, and the case rates are rising. And the best way to look at this is by percent positivity, and this gets around healthcare seeking behavior. So often just because zip code doesn't have a high case rate doesn't necessarily mean there's no cases there. It just maybe means that people cannot get tested. So we use percent positivity as a way to try to get around this bias to see where kind of the incident cases are. And you can see very clearly that South Brooklyn, again, this is percent positivity from the last 4 weeks, but you can see South Brooklyn is where we are most concerned. You can see that percent positivity is 6.64% over the last 4 weeks in Graves and Homecrest. We've also seen Bensonhurst, Borough Park, and Midwood, as well as this is Flatlands, Midwood. So this is the area of most concern. We've also seen a cluster in Far Rockaway, and we've also seen clustering in Central Queens, although it's less strong. We are still concerned, Central Queens, especially Kew Gardens and Forest Hills. And then more recently, although it's not shown here, we're seeing clustering in Williamsburg. And just a side note, the way that we detect clustering is not based on any geographic boundary, and it's a complicated series of algorithms known as SAT-SCAN, which tries to detect clusters through space and time, regardless of zip code boundaries. So all of the recent media around clustering, it's a little bit complicated to communicate because it doesn't necessarily rely on defined boundaries like zip codes or community districts. So there is a cluster, but it's in Williamsburg, but it kind of crosses a number of different zip codes. And hopefully we'll have some more detailed guidance coming out from the health department about that. Also just want to highlight there's a table behind this map as well. So if you are interested to look at these numbers yourself, you can see this is sorted by percent positivity. So you can check out that, again, we see this as our highest, and you can come and see the lowest neighborhoods. You can also look at test rate. So we are particularly concerned when we have instances of low testing rates and high percent positivity. This is where the city is keeping an eye on in terms of trying to focus hyperlocal resources for increased testing and mass distribution and such. So that is the most recent page. I'll also point you to the testing page, which is getting more attention recently. The most important thing on this page at the moment is citywide percent positivity. We have the dark line here is citywide percent positivity over time at a 7-day average. You can see scrolling over this line, you can see it's holding roughly around 1.2, but it is starting to increase ever so slightly, driven primarily by what's happening in South Brooklyn and Central Queens. The dotted line behind it is the daily values, and it is a little difficult to see, so I often encourage people to go to see the raw data themselves, which is in this tests file. And if you're very interested, you can scroll all the way down to the bottom, and you can see here this is the number of people tested, the number of people positive, and the citywide percent positivity by day. And then this is the 7-day average. Excuse me, right here is the 7-day average. And there was a lot of discussion earlier this week on crossing the 3% threshold. And so on Sunday, we had a percent positivity of about 3.2%, which is concerning because the city has decided that once the citywide average exceeds 3% for a certain number of days, I believe it's 7 days, then there might be action with regard to schools and potentially other action. But one thing I really would like to note is that Sundays especially are typically higher because it's biased toward hospitalized patients. So because a lot of clinics and outpatient settings are closed on Sundays, the patient population for Sundays is typically sicker and more likely to test positive. So we have seen consistently higher percent positivity on Sundays, but because we're creeping up higher and higher as a city, this is starting to draw more attention. So just want to kind of caveat that because that's going to have drawn a lot of media attention and will likely continue to do so in the future. So I think I might leave it there. Just before I go, I suppose I can just point out this is the number of people tested by PCR over time, and you can see we're still very high. It's averaging about 32,000 people per day tested including weekdays. And I believe I've gone over this before, so we have a lot of serology data as well on this testing page. But for the moment, the most, I think, pertinent information is this percent positivity. So I will leave it there, but I'm always happy to take questions, and I'll stand by. Thanks.
Thanks, Dr. Thompson. That was great, as always. And then I'll give you just a quick update now on our guidance before we get to the special our special vaccine presentation. This is just a note about testing. So several of you have point-of-care tests, meaning that you are doing nucleic acid amplification, antigen or antibody tests that don't go to a lab, but actually have results within a couple of hours and are done with machines located on site at the places where you practice. So these results, just like any other SARS-CoV-2 test results, are required to be reported by the state, by New York State, through the Electronic Clinical Laboratory Reporting System, or as we call it fondly, ECLAIRS. So if you have any problem with ECLAIRS, you can contact the City Health Department's ECLAIRS team, which is nyceclrs@health.nyc.gov. And we also have a help desk number, which is 866-325-7743 for the state. And then the state is just eclrs@health.ny.gov. Like I said, the webinar slides will be available after the presentation. And you can definitely reference the slide if you need to. In the case that you have these machines, but you do not have ECLAIRS reporting capability established, you can use the Health Department's Reporting Central online portal. And if you also don't have access to Reporting Central, it's in general a good idea to have that access. And you can get there, and you can get that access by faxing a completed universal reporting form to the number we listed. Again, this is only a temporary measure until you gain ECLAIRS capacity, and then the links for all of this information are at the bottom of the page. Can you advance the slide, please? So in addition, there are a few data points which previously may not have been reported, but now are required to be added to a laboratory requisition form. And I'm sorry, I'm saying, can people hear me? I'm hearing questions about the sound.
Yes, I can hear you. Thank you.
Okay, thanks. I'll just continue then. So these are pieces of information that a provider who is requesting the lab must ask for, and this must be reported in addition to the SARS-CoV-2 results. So if the individual attends, works, or volunteers at the school, and then the name and address of the school, there is an occupation field, but the requirement is really exposure or spending time in a school. The place and address of employment, the employer phone number, full residential address and phone number, a local address if the person is not, if that is different from the residential address or the permanent address, and then, of course, the race and ethnicity. Similarly, any licensed professionals authorized by the New York State Department of Health Physician Office Laboratory Evaluation Program, who administer influenza testing, must also report via ECLAIRS, and this is within 3 hours of receipt. And can you advance the slide, please? Another piece of guidance relates to the clusters that Dr. Thompson described and the new emergence of transmission in those clusters. And so on September 25th, and the commissioner issued a commissioner's order, which was updated on September 28th, that non-public schools, so that's private schools, independent schools, charter schools, in 6 Brooklyn and 2 Queens zip codes, which Dr. Thompson described, are subject to this order, which I'll describe in the next slide, but is basically strict adherence to COVID-19 guidelines. And this is because these areas, these zip codes, account for less than 7% of the city population, but have experienced over 25% of the new cases in the 2 weeks. And I think Dr. Thompson talked to us about thresholds for percent positivity, where she was talking about 1% being, exceeding 1% being somewhat concerning, exceeding 3% being very concerning. And you see the you can see the percent positivity for these zip codes is, is as high as almost 7%. Other zip codes will be added as necessary. And, so the city is keeping a very close eye on the percent positivity of all zip codes. So for your reference, and in case you are asked about it as a provider, the specific requirements issued in the order, for the designated zip codes are also, general guidance. So this is really that the order is enforcing adherence to guidance, but this is the guidance that schools should be following, which is, of course, physical distancing. So that's remaining 6 feet apart while on the premises, of course, except if it's hazardous. Also, physical distance does not necessarily have to be maintained when physical barriers are put in place between individuals, and there's specific state guidance. Face coverings are required for everyone in all school buildings at all times, except for a few small exceptions. You can also look at the health department website to understand those. They've listed medical, developmental, and age. The age cutoff is 2 years old, so it's not just young kids. And I really encourage you to look at the website for specific guidance on what medical and developmental means, since I think many of the providers on this call will get questions about that. Coordination and cooperation with the health department test and trace corps. There are specific protocols for opening and closing schools if there are confirmed cases of COVID-19. And these are also any protocols for opening and closing if a student or staff member is confirmed to have COVID-19. Also, exclusion of symptomatic students and staff persons who are confirmed to have COVID-19, or, and this is very important, someone who has been identified as a close contact of someone with COVID-19 whose testing is still pending. And the wording and information related to that order is also on our website. We can put the link in the chat. And now, if you can, oh, sorry, I think we didn't advance the slide. Sorry about that. I missed that. But here are the requirements. I apologize. I should have said advance the slide. But now I am very pleased to introduce Dr. Jane Zucker to talk to us about vaccines.
Thank you very much. Just doing a sound check that I'm coming in clearly.
I can hear you, yes.
Oh, okay. So anyway, it's my pleasure to be on today's call and to introduce some of the considerations for COVID vaccine planning and distribution. I do expect that there will be a lot of questions. And just to preface this up front, that this is really evolving very rapidly, and the information we receive really changes every week. So the health department, we fully intend to keep everyone updated as we get more information. So next slide, please. So what I'll do is briefly touch on the status of COVID-19 vaccine development, some of the characteristics of the vaccines, what the planning assumptions are, how we anticipate vaccine allocation to go, and then what key steps are for providers. Next, please. So there are 6 manufacturers who have received funding from the federal program, Operation Warp Speed, and that's to produce a COVID vaccine to be available in early 2021. The idea is that vaccines that have a good chance of succeeding would be manufactured in advance, so that if approved by FDA, they would be ready to go instead of first starting the manufacturing process at that time. There are 4 vaccines that are in phase 3 trials in the U.S., and the goal of these trials is to assess vaccine safety and also whether the vaccine can prevent COVID-19 infection. So these are the vaccines. There's the Moderna mRNA vaccine, Pfizer mRNA, the Oxford AstraZeneca DNA vaccine is actually on a clinical hold in the U.S. It was on a hold in the U.K. and has restarted there, but is still under review by the FDA here. And then Johnson & Johnson, along with Janssen, they have a DNA vaccine. I will just say that all 4 of these vaccines do have sites in New York City. So just in summary, I didn't want to go through all the details of the vaccines, but all the published data on the phase 1 and phase 2 trials and also animal challenge studies with these vaccines have demonstrated good humoral and cellular immune response. The safety profile is acceptable, although these vaccines are very reactogenic. And so what that means is that there are a high proportion of recipients who do have local reactions in terms of injection site pain and redness, and may also have systemic symptoms such as fever, headache, or muscle aches. For those of you who are who would administer Shingrix, the shingles vaccine, it's not too dissimilar to that. Next slide. So these phase 3 trials are designed to address vaccine safety and effectiveness. They are all randomized, blinded, and placebo-controlled trials. They're enrolling participants age 18 years of age and older, although Pfizer just got approval from FDA to lower the enrollment age to 16. These trials do not include persons who are immunocompromised, pregnant, and do not include children at this time. FDA has issued very clear guidance for licensure for these vaccines, and they outline all the detailed regulatory data that the manufacturers are expected to submit, and they are expecting to see effectiveness data as well, with a minimum vaccine effectiveness of 50%. Next. So the 2 vaccines that are expected to become available first are the Pfizer and the Moderna mRNA vaccine. And this is just because they are furthest ahead in their enrollment. Their target was 30,000, and Moderna's is closer at that point. Pfizer did increase their enrollment to 44,000 persons. But these vaccines are more challenging than the usual vaccines that you would be used to storing in your facility. Certainly if you give mostly flu vaccine. So the Pfizer vaccine is going to be shipped at -70, so this is ultra cold, and it can be stored in the shipping container with replenishment of dry ice. It can also be stored for up to 5 days at -20, and this is a standard vaccine freezer temperature. For example, facilities that have varicella vaccine is likely to be a 1,000 dose order minimum. They're expected to come in 10-dose vials and require reconstitution. The Moderna vaccine is shipped and stored at -20, although this can be stored at 2 to 8 degrees centigrade, and this is a standard vaccine storage temperature for up to 14 days. And these minimum orders are likely to be 100 doses, and these will come in 5-dose vials with no preservative or reconstitution. So you can see just from the storage requirements that the facilities that will be able to receive the vaccine will be limited, and also given the volume, like 1,000-dose orders, that really initially targeting larger facilities. Next slide, please. So what we're anticipating, and for those of you on the call who may have been around for H1N1, some of the distribution will be similar. Vaccine is expected to only be available either directly through CDC or through the New York City Health Department, and this is initially when there's limited vaccine supply. CDC may be contracting with chain pharmacies directly for vaccine distribution, and in particular to give vaccine, administer vaccine at long-term care facilities, and CDC is expected to give vaccine directly to sort of federal entities, including the VA hospitals. So obviously, as I said, distribution will be limited by vaccine storage and handling requirements, and we expect that 2 doses will be required. These are intramuscular injections. And what's also going to be tough is that the products won't be interchangeable. So if you receive vaccine A, you will be expected to receive vaccine A for the 2nd dose, and you won't be able to administer vaccine B. So we will, that will.
Hi, Dr. Zucker. It looks like you accidentally muted yourself. Uh-oh. Oh, there you are. You're back. Thank you.
Oh, good. Okay, so where did I go out? Sorry. What was the last thing that you heard?
I think you just started talking about distribution.
Okay. So just to say that, so do I need to start from the top of this slide?
No, I think some of the participants here are letting us know that the last thing they heard was the bullet about intramuscular administration.
Okay, great. Okay, thank you. So, and the products will not be interchangeable. So again, if you receive vaccine A, you need vaccine A for the 2nd dose, and that will just make it a little more complicated, and we'll have to take that into account when we are processing orders. And vaccination supplies will be shipped in a separate box. So you can expect to receive needles, syringes. There will also be face masks and face shields, which would go along with it, alcohol pads, and a few other things. Next slide, please. So we are expecting the vaccine to become available in 2 phases. Phase 1 would be very limited availability for the highest priority groups, and this could be as early as November 2020. I'll just say that this is our planning assumption to be ready in case it happens. And then phase 2 would be greater availability, and then vaccine available for the general public, and this would be sometime early in 2021 or mid-2021. Next slide. So for phase 1, again, limited supply. Initially, the planning assumptions we've been given are 3 million doses initially for the country. How much of that would come to New York City isn't known. We don't have any information about what our allocation will be. And then again, the projections are as much as 20 million doses by the end of the month. Any vaccine that would be available in November would be likely available under an FDA emergency use authorization and would not be a licensed product. And then I had mentioned this distribution in terms of CDC distributing directly to federal locations and some other national entities. And again, because of all these characteristics, we do expect vaccine to initially be offered at a smaller number of sites that can reach the target populations. For example, hospitals and large medical facilities to reach healthcare personnel. Next slide, please. So for phase 2, this would be expected to be a licensed vaccine product with greater availability to the general public. And I mentioned that production is expected to start before it's licensed, and the health department would have a larger role in vaccine distribution. And what our expectation is that we will expand on what is already an existing vaccination infrastructure in the city. So we're talking about federally qualified health centers, independent healthcare providers, pharmacies, urgent cares, hospitals, VH&H facilities, New York City COVID testing sites, as well as using community vaccinators to hold clinics as needed. Next slide. So the allocation is still under discussion, and so this is just sort of what we know at this point. I think it's important to note, and these are the Advisory Committee on Immunization Practices principles, that for vaccine, what our aims are to reduce the health impact of COVID-19, reduce transmission, that vaccine must be safe and effective, and ensure equitable allocation and availability. There is a national vaccine allocation framework that was the National Academy of Sciences, Engineering, and Medicine has met, and they actually issued their final framework this morning. And in there, so this will be updated if necessary, but they were thinking of their initial doses, what they had proposed were that it would include healthcare workers in healthcare facilities and first responders, and specifically persons who are at high risk of exposure. And then the ACIP recommendations are in development. They've been meeting monthly since June to develop them, and the priority groups that have been under discussion include healthcare personnel, and I think that's also where our focus has been, just because we know that they're going to be part of that, whether it's phase 1A or tier 1, whatever terminology they use. But also under discussion are where in the sequence would adults age 65 and older be, persons with high-risk medical conditions, long-term care facility residents and or staff, and also essential workers. And then also under discussion are what is an essential worker. We don't expect these recommendations to be finalized until the last week of October. I will say that ACIP will likely not issue recommendations until there is phase 3 trial data available. So this timeline could change. Next. Again, so as I said, the initial targets expected to be healthcare personnel, and just many of you would be familiar, but the definition for healthcare personnel, the link is there. We're using the CDC definition, and this is really what's used when you're reporting flu vaccination in a facility through the NHS and to CDC. So these are really paid and unpaid workers in a facility, and this includes not the clinical staff, but it includes all staff that are needed to make a facility run. So that's security staff and janitorial and food service, receptionists, admin staff. So it's really across the whole board that are included, but we really are expecting vaccine to first be given to those with a high risk of exposure. And then these are the other lists in terms of other people at increased risk of COVID-19 complications, but again, it's unclear how the vaccine will be sequenced, and it in part depends on the vaccine characteristics. For example, you wouldn't recommend a vaccine for someone 65 and older unless you knew that it was effective for that age group, and so forth. So without knowing what the vaccines will actually be, it's very hard, and how much we're going to have. We have sort of plans for how we might sequence this, but a lot of this is still under development. Next. So for vaccine distribution, all medical facility networks and individual facilities, when we start enrolling them, will be required to sign a federal provider agreement. This was done during H1N1, and if any of you on the phone are part of the Vaccines for Children program, you sign an agreement for that. And each administration site will need to be identified, again, because many of the larger facilities have more than one physical site where they may be administering vaccine. We expect vaccine to be sent to a facility's main pharmacy, and that it would not be ordered by separate facilities, clinics, or practices. During H1N1, it was actually quite challenging that you had multiple different clinics and departments within a hospital ordering vaccine, but we expect this to all be coordinated, again, through the facility's chief medical officer and the main pharmacy. And this initial vaccine would include emergency medical services. So for a hospital, we would expect them to vaccinate the EMS personnel that serve their hospital. Next. So this is just a screenshot of the provider agreement. It will be signed by the chief medical officer as well as either the chief financial officer or the chief executive officer. The requirements are to administer vaccine in accordance with ACIP guidance. And you will have to report any administered doses within 24 hours, adhere to the vaccine storage and handling requirements, have a way for inventory management. There's some provisions around billing. We do expect that the vaccine will be provided free. We do expect that facilities will be able to bill for an administration fee, and then also a requirement to report vaccine adverse events. This is really no different than the VFC program, and there are some more provisions, but these are sort of the key ones. And that reporting the vaccine doses, I'll come back to in a moment. Next. So this is section B, and this is just the provider profile. And we need the contact information for facilities, their shipping location, size and type of population served, the number of staff, type of facility. The vaccine storage capacity is obviously going to be critical given the requirements of these vaccines, and then specific information about providers. None of this is actually that unusual. I mean, we collect this information through the VSC program for that population and program. Next. So the provider agreement is expected to be available and completed within our citywide immunization registry. So it will be all electronic. We currently do this now for the VOC program, and we also expect that vaccine will be ordered via an online system, and that system is also in CIR, and this is what all providers are using for VOC. Orders would be reviewed and approved by the health department. We would expect sort of initial smaller shipments, and then more increasing amount of vaccine as we've got more vaccine. What we do when we get these orders, this VTRAX is a CDC application, and we sort of download the orders and upload it into their ordering system. Vaccine would be shipped directly to the facility from either the vaccine manufacturer for the frozen vaccines or from the CDC distributor. And again, as I mentioned, the reporting of all administered COVID vaccine doses is expected to be required, and this would be vaccines are required to be reported now for persons 18 and younger. Adult vaccinations can be reported with consent. Again, so the vaccine doses, we did this during H1N1 and people were able to comply. There's been a lot of investment in reporting, and many of the larger facilities are already reporting vaccine doses to the registry. We've been doing a lot of outreach to various provider types to sort of get them enrolled in CIR and sort of be ready for vaccine distribution. Next. So I think what we really wanted, we wanted to present this so you all can sort of start thinking about this now, and I think especially the larger facilities. How would your facility allocate initial doses of vaccine? Right, you're unlikely to get enough. So just speaking for a hospital, you're unlikely to get enough vaccine for all your staff. So who should get it first? It's thinking about who's at highest risk, who has the greatest exposure. So it might be all the staff who are working in the ICU, maybe in the emergency department, and then adding a sort of equity lens to, how again, who gets vaccine first. Persons who may be at risk of exposure from the community where they live, and you want to protect them, that people who are at high risk of complications. And I think as we get more guidance, we will sort of have more discussions, but I think it's important for people to start thinking about that. And again, I've been suggesting that people think, like, if you only have 10% of the vaccine you need, who gets that first 10%, and then who would get, the next, like if you have 30%. Because these are going to be really, I think, hard decisions, and really will need a lot of discussion. And again, focusing on who are the highest risk personnel, given, keeping in mind what the definition, that it's really all staff working in the facility, would be at risk. And then, as I mentioned, people who may be at higher risk of complications if they got sick. And then start to consider how you would vaccinate your patients. Ask now, is your facility registered with the CIR? Do you have a CIR account? And is your facility reporting adult vaccine doses? So many of you on the phone may not actually deal with reporting. We're getting a lot of data directly from electronic health records. So, it's happening sort of seamless in the background. And so I think a good place to start is the conversation with, because pediatrics would be familiar as well as the CMO and the pharmacy people. And we've also been actively outreaching, for example, to hospitals that aren't reporting adult vaccine doses in federally qualified health centers. We do have our email there for CIR, and we can take questions about reporting through there. Next slide. And here, these are just general, I can turn it over, resources on COVID-19 from the health department. And Dee, do you want to take it away?
Sure, I would love to. So Dr. Zucker was correct. These are the health department resources. The schedule of the webinars are every other Friday. You can sign up to receive an email. There's a lot of good information here. And then next slide, please. everybody's favorite part of the webinar, how to get CME from it. We have a link here. It's http://cme.nychhc.org. Definitely get your CME and don't do like I do and wait until right before I have to recertify. And I think that is it for the presentation content. We have a lot of questions, so I am just going to get into them. So Dr. Zucker, can you just talk about consent for, this vaccine that will be very new and will be under an EUA and what providers have to consider? We also have a special question about the foster care population and about children.
Okay, so on the federal requirements under an EUA are that the same way that when you vaccinate, you give a vaccine information statement, there would be information required to be given to the vaccine recipient, and you would get consent as you would otherwise for a vaccine, but there's no other special provisions. It's not like under an investigation of a new drug protocol where you actually have very detailed, multi-page forms to complete with very detailed informed consent. There's not a requirement under an EUA for that. So there are no trials currently in children. They're being planned for next year. So children would not be part of this initial distribution.
Great, that answered another one of our questions. We have a question about how much time will elapse between the two injections.
So if it's the Pfizer product, it's 21 days. If it's Moderna, it's 28 days. And the 28 days is sort of more standard.
Great, thank you. And sorry, go ahead, Jane.
No, do you want me to go through the chat questions or do you want to pick them?
Yeah, we have some and usually I aggregate some of them.
Go ahead. Okay, go ahead.
So no worries. So we have a couple questions about vaccine requirements. We have specific questions about providers, congregate care settings, and how that will, if requirements will impact prioritization.
Yeah, so there's no discussion about requirements at this time. And, any requirement would actually would require action at the state, first off, and not the city. But there isn't a discussion because we don't have a licensed vaccine product, and I wouldn't expect any conversation about requirements until we actually, have a licensed vaccine and have the safety and effectiveness data.
Great, thank you. And can you talk a little bit, you get through questions faster than any of our other presenters, Dr. Zucker. Can you just talk about what an mRNA vaccine is?
Sure, that's like a whole nother, basically, it's taking the genetic material from the vaccine in the RNA, and there's a sort of wrapped in these lipid layers, these sort of nanoparticles, and then when they're injected, the mRNA sort of codes for the spike protein of the sort of SARS-CoV-2 virus, and so then you're producing just the protein, right, that spike protein, and then that your body reacts to that to, make antibodies and respond with cellular immunity to offer immune protection. So it's similar to there are no other mRNA vaccines that are licensed, but it's sort of a different way of delivering, the spike protein that's, needed to induce antibodies. And that's a whole other conversation about exactly which spike protein and which part of the protein is being delivered, and there are some variables or differences across the different vaccine products.
Great, thank you. And we just got a question, which I think you spoke to the fact that there aren't requirements at this point, but can you just sort of comment on kind of the ethics, et cetera, of employers requiring a vaccine for employees to come to work in the office or even to be hired in the first place?
So I think that's a sort of larger conversation beyond this COVID. I think there are requirements at the state level now for certain facilities for people to receive a flu vaccine, when the state commissioner declares that flu is prevalent. If people haven't been vaccinated, then they need to wear a mask when they're doing direct patient care. Obviously, everyone will be masked now, but there are current requirements that are in place. And there are, I know there are hospitals that do require their employees to be vaccinated. So I think there's certainly precedent for doing that. And it's, for one, my personal opinion, I think for flu it's important. It's increased healthcare worker vaccination. It's really about patient safety. It's about the health of the healthcare worker. We know flu vaccination will reduce absenteeism, for example, and reduce illness. But it's also about not wanting to get your patient sick. So I think we have a long way to go before we have a conversation about COVID vaccine requirements.
Great, thank you. And I think, Dr. Foote, you just answered this in the chat, but we have a question about saliva tests for diagnosis of SARS-CoV-2 infection.
Hi, yeah. Actually, this has been something that has been a bit of a disappointment so far in terms of research and development. There was promising results at first, but the companies that have been pursuing approval for saliva-only home-based tests tend to be performing inferiorly compared to anterior nares swabbing. So it seems like a lot of those kind of rapid testing efforts are moving more towards nasal. So short answer is at this point, there's no saliva-only test, rapid test that is approved for saliva only. So stay tuned. But the Times had a really good article about this, I think, just yesterday, summarizing the issues if you want to take a look. Thanks.
Great. And then, yes, I just want to alert everybody to the fact that the poll has gone live. Please fill it out. It helps us tailor the content of this webinar. I think we have gone through most of the questions. Dr. Thompson, you spoke a little bit about this in your presentation, but can you just talk about the variation in testing that happens based on days of the week and why our percent positivity might be higher on a Sunday? Dr. Thompson? Corinne? Dr. Foote, I think we have the answer written down. Do you think you can answer that?
Hey, sorry about that. We are just having sound issues today. Yeah. So really the main issue, and Dr. Corinne had a really nice explanation, is that because most of the clinics and other outpatient testing sites are generally closed and not actively collecting samples on Sundays, then a majority of the results reported from Sunday collections are from hospital, which they tend to have a higher positive predictive value, so tend to have a higher positivity rate in hospitalized patients.
Great, thank you. And I think for all our panelists, I think this is, I can speak a little bit to pieces of this. This is almost a webinar in itself, but we do have a question about current treatment recommendations for hospitalized patients with COVID. I think, I can answer a little bit of it in terms of, severely ill patients and ICU patients. I think there has been, and I'll just say briefly because it's not really a 5-minute topic, but there, at the beginning of COVID in February, March, April, there were a lot of questions, I think some of which we discussed here, about strategies for COVID, steroids or no steroids. Do you do invasive ventilation? Do you do early invasive ventilation? And I think that several of those recommendations have settled out. I think the Society for Critical Care Medicine actually recently published a sort of new consensus guidelines based on what we have learned. And some of the things, I think steroids is the biggest one, where it was very, very controversial. And it was only in April that actually Dr. Pastores from MSKCC in New York published this really, really groundbreaking paper on the value of steroids. They often use, several institutions often use steroids with IL-6 inhibitors like tocilizumab, which can be profoundly immunosuppressant, especially when used together, and especially the steroids. It's turned out that steroids are cheap, readily available, and also very effective in many situations. Does anyone else have anything to add on that from our panel?
I would just, if you're interested in kind of most up-to-date evidence, I would refer you to the NIH guidelines and the Surviving Sepsis Campaign guidelines, which have a nice summary of the evidence behind the newest recommendations.
Yes, that is the one I meant. That is the one I meant when I said critical care medicine. Thank you, Dr. Foote.
Yes, I put the links in the Q&A.
I think in terms of therapeutics, we can give, again, we have like 2 minutes, but in terms of therapeutics, I think that, we have heard about some promising results for remdesivir in early, in very ill patients. I think that trial for remdesivir, they added another drug, baricitinib, which is an anti-inflammatory for rheumatoid arthritis, into that trial, the ADAPT trial for me. And that drug, baricitinib, also has some promising results, but those are for severely ill patients. I think there's kind of a bucket of different therapeutics, but as therapeutics go, my understanding, and please correct me, other panelists, is that the only one that is kind of like out of the park, a really good treatment, is the steroids. Which I can just say, I did not expect would happen. I was part of the camps that thought that the steroids would alter the course of illness, and that by the time they were useful, they would be too late. But I was wrong.
Yes, and just touching on convalescent plasma, that as of now is shown kind of mixed results, so it hasn't really proven to be a slam dunk therapy that people are hoping for, but it's still being used under experimental protocols. That's all.
We have anticoagulants and vitamin C. So vitamin C for 1 minute. Vitamin C, again, I don't think that it has really panned out as a therapeutic agent on its own. It's not really harmful at the doses that it was being given under investigation. In terms of anticoagulants, that's something that we're finding more and more about every day. I think we gave a presentation specifically on coagulation in COVID-19, but there is very profound coagulation, often in people who do not appear very ill, and this is not the kind of this exceeds the kind of anticoagulation, this exceeds the kind of hypercoagulability that we see with systemic inflammatory responses. This is plus on that. So there aren't, in most places for people, unless someone is quite ill or has, quite ill in the hospital, sometimes people will do it for elevated D-dimers, but most people aren't doing therapeutic anticoagulation for persons with COVID, unless, of course, there is a normal, regular indication like the existence of a deep vein thrombosis or other clotting. But it's a mystery. I mean, there are definitely patients, and the coagulation cascade, as you would expect, seems to get much, much worse with severe illness. But we have seen autopsy results have showed significant clot or even clot as a cause of death in patients on full therapeutic anticoagulation. So I think that is an answer, or that's something that we're still investigating, but everybody is anticoagulating sick patients a lot. There's a putative role for aspirin, especially given the cardiac effects that we talked about, I think, 2 weeks ago. There's a therapeutic role, or there's a potential therapeutic role for aspirin. And I just noticed we're 2 minutes over time because you got me talking about ICU care. So thank you to all of our panelists. Thank you all for coming, and we will see you again in 2 weeks' time.
Okay, thank you.